So when we talk on about a medical record, there is a lot of information, from the nurses, from the doctors, from the labs, from the dietitians, physiotherapists. There are tons of data. So we need to kind of filter out the data, what we need as pharmacists, as healthcare providers, collect all that information in an organized manner, and then put it in the form of a SOAP note. Whenever we are reporting or we are handing over care from one person to another, if it is not organized, it is very difficult for them to understand, right? So that is why we use a SOAP note. And this also helps us to use our skills, our clinical reasoning to assess a patient and try to see what kind of recommendations we can give to the improve the health of the patient. And these SOAP notes, we have different terminologies, variations, and how we collect or write a SOAP note. We have what is called as a farm note. And these also depends upon the type of setting. So whenever we talk about pharmaceutical care, right, we are so focused on the outcomes. What are the outcomes that we are, looking for in that patient? How is the patient doing? When is the patient coming back to us? And, what kind of care are we giving? And in this case, pharmaceutical care, it also depends upon how much time we are spending with the patient. So we need to document when we are meeting them, how much time, and how we are billing them, etc. So one issue what we normally have whenever we are documenting our case is the patient might be there for 2 days in the hospital or might be there for 30 days in the hospital. So we have a lot of data, and the health status of the patient changes from day to day. So we have blood pressure monitoring for, like, say, the 30 days, every shift. So as students, what you normally do is you start writing down the blood pressure details of the entire stay in the hospital. And that can be overwhelming because you have a lot of data. So typically what you need to do is look into, okay, is the blood pressure normal? Is it not normal? Are there fluctuations? Are there minor fluctuations or major fluctuations? And also try to write down the range. As long as you have the range in the blood pressure, that should be fine. You don't have to write down every, the blood pressure at every shift change or whatever. Similarly, all the lab values, because they can, turn to pages. So it's one disadvantage with the SOAP note whenever we write is we cannot change it. As the health changes with time, it's very difficult to keep up. So that is one thing that we need to keep in mind when we are doing a SOAP note. So when we are writing a SOAP note, what do you understand from subjective? Can any one of you answer?
Symptoms, ma'am.
Symptoms, okay. Next slide, please.
What patient tells what he experienced.
Okay. What they experienced, right? So it can be from the patient, it can be from the caregiver, family member, anybody. So here, what are the symptoms? What the patient is feeling? Say, for example, the patient says he's having fever. That can be a symptom, right? But when we check the temperature and say the temperature is, 103, 102, that is a sign that becomes objective, right? Whenever we can check it and then we can verify that. So subjective is basically what story the patient tells us when they come for the visit. So it is, we normally include the chief complaint. So as soon as a patient walks in, they say, oh, doctor, I'm here to see you because I'm having, abdominal pain, or I'm not feeling good, I'm feeling dizzy. So these are, the sentences that the patient tells in their own words, and they hold a lot of importance. But not only that, but what else are they saying or not saying? That needs to be captured by the healthcare provider. So for the sake of, having a completion, I'm just giving you what all the things that we include in a SOAP note. I'm sure you're aware of all these, so you're not new to, these things. So excuse me if you feel a little boring, but I need to quickly go through all of these. All right, is that fine with you?
Yes, ma'am.
Yeah. So after the chief complaint, we talk about the present illness, history of the present illness. So it is not only what I'm feeling right now today, but how was I feeling the last few days? What happened? It's like a small story. So it's elaboration of the chief complaint. And we also ask about the medical, illnesses, what they have, the other comorbid conditions. We include the medication history. Uh, Also important to see that we have the over-the-counter medication, surgical, family history. So a couple of things, all these are very, very important in their own way, because when you know about the family history, you know the risk factors, social history. Nowadays, all these days, social history was not given very a lot of importance, but it does play a huge role. When you talk about social history, it is what kind of occupation the patient is in. Is it a student, or is it an employer? Is it a businessman? Or what kind of family do they have? Are they married? Are they single? And what about their drug abuse? What about their alcohol intake? And most important, what is their financial condition? Especially in countries like US, all these play a very important role, because there are case workers. There are social workers who manage the patients. If they are not able to sustain themselves or help themselves, they have arrangements for the patient. The patient is not left to their own misery, because the state also takes care of the patient to a certain extent. So these become very important. So the review of the systems are both subjective as well as objective. So whatever the patient tells you, you can, add it to the review of the systems in the subjective section. And medications and allergies. So you have to understand one thing. What the patient tells you can be subjective, but if you're taking the same information from a medical record, the patient's allergies or the current medications you copy from the medical record, that will be an objective information. Usually the first hand will be subjective, and from the medical records will be objective. So it can be both. Next slide, please. So here, when you call as objective, most of these are reproducible. As I told you earlier, a temperature of 102 is objective. A patient says he has abdominal pain, that is subjective. But when the physician palpates the abdomen and the patient presents with the pain, then it can be objective in nature. And as well as, all your lab findings, your imaging, diagnostics, all these become objective data. Can you see me properly? Is there a lot of light?
No, ma'am.
It's okay? It's okay? All right. Next slide, please. So assessment, it's one of the most important things. So once we have the subjective data, we have the objective data, we arrive at our assessment. So we are looking at the diagnosis. I have discussed about the diagnosis later in another slide. But here, what do we think are the patient's problems? Most important, we have to remind ourselves as pharmacists every day. We are doctors, but we are pharmacy doctors. We are not medical doctors. Students do get carried away once they go to the hospital, right? So as long as you know who you are, what your role is, what your limitations are, then you know what should be your focus. So in the case of assessment, we do prioritize all the patient's problems. We make a note of them. What are the medical problems first? So once you list out all the medical problems and you see what medications they are on, what treatment they are getting, your planning becomes very easier. Your assessment also becomes much more clearer. So we have to prioritize the patient's problems. We have to see what our goals of therapy are. We need to see where is the patient at their goal. Are they at the goal? Is the condition uncontrolled, or is it controlled, etc.? And then we have to focus on the medication related problems. Next slide, please. So the doctors, once they diagnose, they do give the treatment, right? They start the patients on the treatment. What is our role here? So we have to see what kind of a treatment the patient is getting, what medications are being prescribed, is the dose appropriate, is it evidence based, what are the other conditions that the patient is having, and is this the right medication at the right dose, right frequency, right? We call it as the rights. All these have to be evaluated. So typically you're looking at each condition, you're looking at the medication and seeing whether this the best treatment that we can give to the patient in this situation. So that is all the assessment is about. But again, it is not very easy as we say. Next slide, please. So here we talk about the medication related problems. You're all aware, right, about MRPs or DRPs? Yes. So when we talk about the drug selection, our focus is always on, are we selecting the correct drug? So there are many factors before we select a medication for a given condition. Say, for example, it is an antibiotic. Antibiotics, we look at what is the infection, what is the severity of the infection, is it community acquired, was it acquired in the hospital, what are the pathogens that are responsible, and that is all that information is based on the culture and the sensitivity tests, right? So we have to look, is this antibiotic appropriate? Does it cover the required pathogen that is in question here? And in a country like the US, we also focus on the race because there are some risk factors in particular races, in particular ethnicities. So we have African Americans. So our blood pressure management also changes when it comes to the African American population or the American Indians, what we call them, the Native Americans. So all these have to be taken into consideration. And what kind of risk factors do they have? And about the dosing. So here, when we are looking at the dosing, some conditions have a fixed dose. You start with 5 mg and then go to 10, 20 mg, and other conditions might be, medications might be weight-based. All right, and then we are looking at the indication also. So the dose has to be appropriate for the patient's age, for the patient's weight, for the severity of the condition, and also for the indication. I have many, cases where we see enoxaparin, right, which is a low molecular weight heparin, which is, based inappropriately. Similarly, overdosing is a problem. Treatment without indication. So we give many drugs, but we don't know why it is given. What is the use of this particular drug? Here is when the reconciliation takes a very important role. I'm sure you all have heard of a medication reconciliation. It is basically synchronizing and reconciliating medications from the time the patient steps into the hospital. Say, for example, a patient fell sick at home. They brought him or her to the emergency room. From the emergency room, they give the treatment. They send them to ICU. From the ICU, once they stabilize, they go to the wards, right? And then they're discharged home. At every level of care change, we see medications being added, medications being, discontinued, doses are reduced. So it is very important that we keep track of what is happening. At the end of the day, when the patient goes home, they need to be on medications that they really need and not any extra and not, missing some of the medications. And untreated indications. Untreated indications come into the picture when there are many specialists, each one coming in, doing their job, taking care of only their, for example, if it's cardiology or nephrology, they take care of only their medications and the other medications might be ignored or not given much importance. So the internal medicine plays a very important role when it comes to organizing all these and making sure that, the patient is being treated right. You also focus on drug interactions, drug-food interactions. All these are also important when it comes to patient counseling, irrespective of their stay, whether they're in the hospital. Levothyroxine normally taken on empty stomach first thing in the morning, but at the same time, if you look at some evidences and some information, It can be taken any time of the day, provided, they take it consistently. So that is what some, clinicians follow. And phenytoin. So, when are they taking? Are they taking immediate release? Are they taking sustained release? Is the patient on tube feeding? So once the patient is not able to have their regular food intake, they might be put on, NG tubes. So when are we giving phenytoin? Are we stopping the feeding, while the patient is probably on TPN? Is the dose being absorbed properly? What are the levels? So all these come into the picture, depending upon how the medications are being taken and their interactions with the food and the other drugs, adverse drug effects. And the last one, and some most important one, is failure to receive a drug. That is a drug being omitted. So this is very commonly seen. The doctor may prescribe the medicine, but the nurse may not give it, she may forget, she might be busy, or the patient is home, but they're not taking the dose. So failure to receive the drug also becomes a very important medication related problem. Next slide, please. I have not presented here a single case. I have taken bits of information, and so that you can understand, irrespective of which case it is, what are the things that as students you need to focus on, what do you need to consider, all right? So when it comes to the assessment, because the plan is also based on the assessment, say for example, there is one patient with diabetes mellitus. Here we have the information of the HbA1c. It is 9%, and what is your goal? And the patient is on 2 medications, metformin and glipizide. So can any one of the student answer me? What are your thoughts? I'm sure I have put some information on the slide, but without looking at them, by just looking at the medication, what do you think? How do you assess? Can any student take an initiative? By
Ma'am,
just
once.
yeah. Go ahead. Yes, anybody?
Actually,
Someone has come forward and you just unmute yourself.
Yeah, please, please speak. I don't want it to be, I have kept this as very informal. This is not a formal presentation from my side. You just sit and listen. Yeah, please tell me.
the normal range of HbA1c is below 6.3%, ma'am.
Okay.
So, but here it is recorded as 9%, which
Okay.
means that the patient is having diabetes, and he was prescribed with metformin 500 mg QD, which is 4 times a day.
QD is once a day, once daily.
Oh, sorry, once daily.
Okay.
Whereas glipizide, it is about 5 mg twice daily. But according to the practice, metformin can be given twice daily and glipizide can be changed to once daily.
Okay. Anything else? Any other comments? You think that medication is sufficient?
And after assessing the HbA1c, we can, if needed, we can add gliptins also, ma'am, to the prescription.
Okay. So how will gliptins help? How will the gliptins help here? Yes, anybody else? I want students to interact and talk, please. Ask questions. So think this is your drug information center, and you're sitting in the hospital and you're looking at a patient with HbA1c 9%, and you have on metformin once a day. What do you do? Do you say that it is appropriate while you're presenting the case? Do you just read out, say HbA1c is 9%, goal is 7, 6.5, 6.3, whatever, metformin, and you go ahead and you present your case and complete it?
No, ma'am.
What do you do as a pharmacy student?
Can we change to insulin, ma'am?
Okay, can we? Should we?
Should we change to insulin, and after decreasing the HbA1c level, then we can change to oral hypoglycemics so that we can maintain the blood sugar levels.
So what is the
Normally.
indication for insulin? At what level of HbA1c should we start insulin? Okay, let me see, as I told you, right? This is not a whole case. I've just given you one bit of information to see, how you will proceed. So first we have to look at HbA1c, right? Is it in the normal range? No. Is it the preferred range? No, it is definitely high. So our goal, see, there are guidelines which say the goal is 6.5%, some say 7%. But as a practitioner, you will always have to see what is feasible. A goal less than 7% is quite reasonable in most of the cases. All right. You go for insulins when HbA1c is about 10%. The patient is having all other conditions, is being frequently hospitalized, or there are other contraindications or reasons why you're not preferring, oral meds. If you look at metformin, right, 500 milligram once a day is like a baby dose. What is the maximum for metformin? Do you know what is the maximum daily dose?
2000.
Yeah, around 2000, right? 2022-50. So that is the maximum dose. Are we utilizing metformin to the maximum
Yes,
level? No, right? Here we are giving only 500 milligram per day. And we're having glipizide 5 milligram, right? Twice a day. So this is not doing much because the HbA1c is not in goal. So what do? You increase the metformin, right? From once a day, you make it twice a day, see how the patient responds. And then if possible, make it 750. We have 850 milligram doses. We have 1000 milligram doses, strengths available in the market. So all these have not been tried. So our initial consideration here is we are not utilizing metformin to the extent that we can. We can go up higher. So what do? We increase the dose, we see how the patient does, and then we go from there. All right. And again, glipizide. Glipizide is which category of anti-diabetic agent? Which category does it belong to? Sulfonylureas?
sulfonylureas.
Okay, so what are the problems with the sulfonylureas? Hypoglycemia, right? Weight gain. These are the issues. All right, so again, even if you want to continue with the glipizide 5 milligram, you can do an XL, that is extended release glipicides. You can make it once a day so that the patient is adherent. So this is one small example, but what are the factors that we consider whenever we want to assess, and then we have to plan, we have to recommend? We have to focus on how much reduction in the HbA1c are we looking for? And what are the fasting levels? What are the basal levels, postprandial levels? And whenever you start any medication, is it going to affect, is it going to reduce the postprandial levels? Is it going to reduce the fasting levels? Is the patient having frequent hypoglycemias? Is that a concern? How much does the patient weigh? Is the patient, within normal limits, or is the patient obese, overweight? what do we need to do? Do we need to add any medication that is weight neutral, like metformin, or do we need to add medications that can also help reduce the weight? All these new medications, DPP-4 and SGLT2, are definitely useful in reducing the weight. What are the risk factors? What are the cardiovascular risk factors for this patient? Do we want any protection? Is the patient having heart failure? What is the renal function? Is patient on metformin? Again, we need to look at the renal function of the patient. We need to look at genitourinary issues that can have. So many medications are out in the market, all the new categories, whether it is what we call as fluoxetines, that is SGLT2 inhibitors, DPP-4 inhibitors, so many insulins in the market, different kind of injectable anti-diabetic agents. What is the cost? I'm not sure the cost in India, but here it is through the roof. Any insulin is one of the most expensive medications that are used commonly. Does the patient have insurance coverage? What is being covered under the insurance? Usually, when, for example, SGLT2 inhibitors, we have so many of them, probably insurance covers only one. So we have to go to that particular drug. Some patients are fearful of insulins. They do not want to take injections, or they are not competent enough. They don't have a good support system at home. They are not educated enough. So all these things are definitely going to affect what kind of a drug we are going to choose for this patient. And here I have a picture of Lantus, that is insulin glargine, which is a long acting. We have Detamir. So here on a daily basis in my pharmacy, we have so many patients on all these new agents, and it becomes complicated. It is not as easy that you start with metformin, take once a day, twice a day, make it extended release, monitor. Those days are gone. The patients also know that there are medications, there are injections which can be given once a week. Who wants to take 3 times a day? If I can have a Lantus and that's taking care of my basal insulin, that's very good. Or there are glutides, semaglutides, dulotide. All these new ones in the market are very, very expensive. At the same time, we need to know when is a good time to add these medications to the regimen. All right, so do we just do metformin? Do we add glimepiride? And then what is the role of thiazolidine diones? What is the role of acarbose, miglytol? So as students, what you need to do is be very thorough. Look at all the guidelines. ADA, American Diabetic Association, has very nice algorithms. I'm not sure how many students go through with that. Guidelines are just guides, right? It does not mean whatever is in there we are going to use all those strategies for our patient. It may work, it may not work, but they definitely help us in understanding what is the way to go. When do we add Jardiance? When do we add Januvia? How much difference does it help in the reducing the HbA1c? If you look at all the data, metformin is one of the best drugs which can reduce the HbA1c by 1 to 2%. Other drugs may be 0.5%. DPP-4 inhibitors anywhere between 0.8 to 1%. So it depends upon what is our goal, where are we, and how do we go about this. Next slide, please. Okay, so this is one from the recent 2021 American Diabetes Association that you can see. So you're welcome to go look at the website, look at all the slides, and have a copy in your folder so that you can go through. Next slide, please. So whenever you're looking at the assessment, right, we need to identify the problems. So those problems will be identified. You have to resolve them, and if possible, prevent them. So as students, focus on the medications. You get lost when you look at all the data, and what I see when students commonly present is the medications are not focused on well. So please do that. Next slide. So plan. Once you have your assessment, then you're going to have the plan. So plans depend upon what are the medications, what changes are you making to the medications, what are you monitoring, how do you monitor the disease state, how do you monitor your medications, the lab work, focus on who is the patient, are they able to pay, what is their educational level, what kind of non-pharmacological therapies do we need to initiate, do they need referrals to nutritionists. All these are included in the plan. So it's basically who has to do the follow-up, what needs to be followed, and when do we need to do it, and also how to do it. Next slide, please. So whenever you're writing your SOAP note, you're doing the assessment, you have to list out all the problems, right? So I call it as match the following. You have a list of conditions. Say you have diabetes, you have hypertension, you have a patient with osteoporosis, anemia. So these are all the medical problems what the patient is having. And you have a list of like 20 medications that has been given to the patient. So an easy way to understand it is make a table. On the left-hand side, you have all the healthcare medical issues. On the right-hand side, you have the medications. So try to match, try to group all the medications, that are being used to treat one particular condition. And once you do that, okay, the patient has diabetes, these are the medications. The patient has hypertension, these are the medications. So any extra medications that does not fall into any of the list of the problems that you're seeing, that's where, we have excess medications. We are giving medications where there are no indications for. Or you have problems on the left-hand side, medical problems, but you don't have medications to treat. That means it's an untreated indication. So think of it as a match the following, and then see for each problem, are we having the best drug? What is it going to do? What is our goal? Are we doing okay with it? Are there any problems? How do we solve it? All right. So all the goals are the realistic. One student mentioned goal is 6.3 HbA1c. That is a very good goal. Fine. Below 6 is even better. But is it achievable? We go step by step. All right. So, and we see who the patient is, what are the risk factors, what is the big picture, and then we set our goals. And all the endpoints have to be evidence-based. We have so much of information. We have to make sure that all the information is interconnected, all the problems are relatable, and our assessments are appropriate. Next slide, please. Sandeep, is it, how much time do we have?
Ma'am, it's up to you, ma'am. You can take another half an hour if possible.
Okay, fine. All right. So as students, what do you need to prepare for your assessments, for your, hospital visits and case presentations? You go through the textbook. DiPiro is like the Bible. You go through algorithms. All the flow charts become very essential, the guidelines. And I recommend you to have a folder for every chapter that you're studying. Go to the organization, go to the, the professional groups, look at their guidelines, look at the position statements. Usually there might be like 50, 100, 120 pages long, but every guideline will have an executive summary of a few pages. So, you skim through those, take a look at those. And ICMR are coming up with some guidelines for our antibiotic usage. Look into that, because at the end of the day, we need to focus on the Indian population. And whenever you're studying pharmacology, the way our syllabus is currently, you may study therapy first and then some of the pharmacology chapters, so that they may not gel well. And if you're looking at some of the pharmacology textbooks, they may not have the same classification of the agents that you're studying in DiPiro. So it's very important that you study pharmacology and therapy together and not treat them as separate subjects. Once you treat them as separate subjects, you're missing out on a lot of information, and that's a waste in time and effort. So try to study them together. And whenever you're looking at every drug, try to have at least 5 to 6 points that you remember at the top of your head for each drug. Say, for example, ACE inhibitors. Can anyone tell me like 4 or 5 points about ACE inhibitors?
Common ADR is dry cough.
Okay. That's number one. And what other 4 or 5 points you can tell me?
Antihypertensive medicine.
Okay.
Contraindicated in case of pregnancy.
Fine.
The choice of drug in hypertension.
These cause hyperkalemia.
Okay.
They act by inhibiting the enzyme, angiotensin converting enzyme.
Okay. So each one of you got a point, right? So what about angioedema? What about bilateral, renal stenosis? Effect of potassium you have mentioned. What about the effect on the creatinins? What effect does it have on the creatinine levels? Do you need to monitor it once you start an ACI?
Yes, ma'am.
We need to, right? So if you're looking at it, what about the renoprotective effect? So why do we start ACE inhibitors? So these are, I don't want to elongate, but I'm just trying to say that for each drug, if you have like the top 5, 6, 7 points, it becomes very important. Which category does it belong to? All right. What does it do? What is the starting dose? All right. Or what is the range? And all these drugs have got what is called as a class effect, right? They work kind of very similar. So what are the contraindications? So every drug, say for example, metformin. Can anyone talk about metformin?
Causes weight gain, vitamin B12 deficiency.
Okay, then?
It is an
Causes
antidiabetic.
renal impairment. It causes renal impairment.
Okay. It causes or it can have an impact on the renal So if it's causing renal impairment, then why are we using metformin in all patients? Majority of them.
It may have an effect on renal functioning, ma'am.
Okay. So you don't use the word cause, right? Yeah.
Okay, ma'am.
So what we remember about metformin, it is a biguanide. Okay. So it is one of the, oldest drugs we have in the market. It has got a maximum, dose of 2000 to 2250 or 500 mg. It is weight neutral. Somebody mentioned weight gain, but it is a drug which is weight neutral. HbA1c can be reduced 1 to 2% with this. All right. We need to monitor the serum creatinine. Definitely the creatinine clearance. If a patient is also having some contrast media, we need to monitor metformin. All right. So it has an impact on the glucose levels, the hepatic output, it has an impact. So these are some of the, somebody's mentioning controlling high blood sugar. Yes. And what are the other considerations? Lactic acidosis is rare, but it can happen around 1 in, 10,000 patients or 15,000 patients. Lactic acidosis is a possibility. We also have to look, it has an impact on both fasting and basal insulin. So like 4 or 5 points on each drug, if you kind of practice, make a note, it becomes very easier. As soon as you look at a drug, you should know what is the indication, why it is used for. So that really helps you. And also the practical experience. So most of the students don't like to spend time in, outpatient, pharmacies, but that will, outpatient pharmacy, inpatient pharmacy, the more time you spend, you will have a practical experience. A good pharmacist is one who knows what is happening at all levels. It's not sufficient if you have a clinical knowledge, but you need to know, is the drug available? What is the cost of the drug? What are the dosage forms that is, that they're available in? If you don't know all this, it becomes very difficult and incomplete for you to manage a case. Next slide, please. So while presenting a case, it's important to know who your audience is. Try to be very clear, organize all the information, have your references ready, and you practice and not have any mistakes in the spellings. Have your slides clear. Next slide. I think I've mentioned. So I had a few questions from the students. I've tried to answer them in the next few slides really quickly. There was a question regarding, I think, lab values. I'm not sure what the question is. Assessment of lab profile values. Which value, elevation, depression is a symptom of which disease? So that's an actually presentation, another presentation entirely. I cannot do justice by covering all of them. But what I can tell you is in your textbooks and also in the internet, you have so many resources where the lab values chart you can get. And even Koda Kimball has in the beginning, it has a very good chapter. So please go through all those. And starting from the second year, you start having seminars focused on these lab values. The way our curriculum is, you don't study clinical pharmacy until the fourth year right now, and where all your some of the topics are when it comes to the labs. And you start your case presentation in second year. So there is an issue where they are not aligned properly. So make sure that as faculty also focuses on giving topics. For example, it is ABG analysis, electrolyte imbalances. DiPiero has very good chapters on all these. And lab values are available in whenever you see any lab value in the medical record or the patient charts, try to see what it is, what it does. I will not be able to cover, what, about all the elevations or the abnormalities in the lab values. And also have a skill lab where, you get small exercises on all these values. So what I did while I was an intern is my pocket had many, many papers with it. Right now we have smartphones. We never had smartphones during those times. So all we had is a paper, like what I call as a cheat sheet. So you can have all the lab values, the normal values, the normal range, and if it is abnormal, if it is higher or lower, what does it? So you can have a cheat sheet of that. And drug interactions, some common, as many papers as you can, have it in small sizes so that you can quickly take a look at that. And there are so many resources on the internet where you can go through them. Next slide, please. I've given you a small example here. So sodium, what kind of an, is it extracellular or intracellular?
Extracellular.
Extracellular. Potassium?
Intracellular.
See, whenever we look at the normal levels, right, somewhere between 135 to 145 milliequivalents per liter. So what if the sodium is higher, sodium levels are higher? What is the cause? So that is what we're looking at, right? So whether there's a sodium overload or there is a volume depletion. So sodium, water always follows the sodium, that we need to remember. So sodium overload can be because are we giving too much sodium bicarbonate? And not only sodium bicarbonate, right? You have so many medications which are sodium salts. What about the diet? What about, the medications that the patients are getting? Are we giving, too much of sodium overload in the form of IV fluids? Or is there a volume deficit, the volume depletion, what we call as the free water deficit? So this is a formula which we use for free water deficit. So every lab abnormality can have many reasons. So what you need to look at is, yes, we are seeing hypernatremia. So what is the cause? So you have to relate it to all the other factors that is going on with the patient. So is the patient having an impaired thirst? Are they losing? Are they having diarrhea? Are they having vomiting? What kind of losses is this is going on with this patient? And that will help us to understand better and then see how we can treat the patient. So what kind of fluid can we give if there is a free water deficit? Anybody? If there is a volume depletion in this case? Anyone? What are the various kinds of fluids that you find in the hospital? IV fluids.
Normal saline.
Okay.
Dinger lactate.
Then
ORS.
IV.
Dextrose.
5% dextrose, ma'am.
Okay. So in this case, what fluid would you prefer? Would you
Normal
prefer
saline, ma'am.
normal saline? But we're already talking about sodium overload, right?
Hypotonic.
Okay. So let me not, I'll just give you, a idea for thinking. So whenever we are giving any fluid, we need to know where the fluid is being distributed in the body, in the space. All right. So once you know that, it'll be easier for you to understand. So we are giving free water here. We need to give solutions which are having reduced sodium levels. We don't want to add to the sodium overload that is already there. All right. The sodium overload, what we call, is a term which is relative. It is relative to the amount of free water that is there in the body. All right. So here we are not giving normal saline. We are not giving half normal saline, which is 0.45%. All right. How many milliequivalents of sodium is in normal saline per liter? Anybody? We just say IV fluid. We just say NS. Have you ever thought how many milliequivalents? Any guesses? Quick guesses?
I'm around 150, ma'am.
Yeah, 154. Half normal will be 77. All right. And dextrose 5% has 0. Right? Sodium.
Yes, ma'am.
Yeah. So this is how you start thinking. Okay, there is a problem here. The sodium levels are higher. Why are they higher? What can we do? Okay, if you are giving a fluid, how much fluid do we give? What do we give? And how do we monitor? All right. So these are the things that we consider for any lab abnormality. So it's important that I think there is a very nice table also in, probably it is DPIR, I'm not sure. You go through those and that will give you a clear example as to all the fluids and where they are distributed in the body. So please go through that and that will help you understand. Next slide, please. Other thing that you need to monitor is the albumin levels. Are they normal? If the patient is having lower albumin levels, then you have to correct for calcium. And you also have to correct for the phenytoin levels, because phenytoin is one important drug which is protein bound. So you have formula for all those. These are available. I'm sure you are familiar with those. Next slide, please. So another question was regarding proper drug selection if improper drug given. I'm not sure, what was the thought behind this, but I'm giving a small example. Whenever we look for a drug, we need to know what is the medical condition that we are trying to treat, number one. What is the indication, right? And we have to make sure that we are giving drugs as per the indication. So here, where do you get that information? We have it in the package insert, and a very good website is the Daily Med website. How many have used Daily Med websites? Anybody? Anyone? No? All right. So whenever, you want quick information, students, you have access to Micromedics, you have access to Lexicomp. Just in case you don't have access to any of these, then students go to drugs.com, Hippocrates, so many other resources. But one standard resource that you can use is Daily Med. You just say, for example, you want information on pantoprazole. You just say pantoprazole on Daily Med. You Google, it'll take you to the Daily Med website, and there you can, have a lot of information. All the FDA approved information is present. So to select a drug, we need to know the indication, we need to know the severity of the disease, and azithromycin. Which category does it belong to? Macrolides, right? So, and they treat atypicals. Can you tell me what the atypicals are? Atypical organisms?
Mycoplasma pneumonia.
Okay. Then?
Mycobacterium tuberculosis.
Okay. Tuberculosis? I'm talking about macrolides, right? Legionella, chlamydia, etc. So here a small example for azithromycin. When you talk about a dose, the dose varies depending upon the indication. This is a very good example. All right. Here we have, for STDs, we can give a 1 gram single dose, or for community acquired pneumonia, we call it as a Z-pack. What is the dosing for a Z-pack? Anybody?
We never heard, ma'am, actually.
Okay, azithromycin, how do you give it as a, what kind of dosing do you do for azithromycin? For community acquired pneumonia?
3 days dose.
Okay. So when what we call as a Z-pack is, it's like a regimen. For the first day, you give 250 milligrams, 2 tablets, that is 500 mg on the first day. And then you give 250 mg each day for the next 4 days, like 250 into 4 days. The first day is 500 milligram. So that is what we normally call as a Z-pack. So the recommendation for community acquired pneumonia is 500 day 1, and days 2 to 5 will be 250 milligram. And for acute bacterial sinusitis, it is 500 milligrams for 3 days. And again, pediatrics, when it comes to that population, it is weight-based. It is not 1 gram, it is not 250 mg, we give it based upon the weight. So for one drug, azithromycin, you have 4 different, indications, 3 main indications and 4 ways of dosing them. So it all depends upon what is the problem, and the dose goes from there. Next slide. And another example I've taken for the OP cases, duloxetine, Cymbalta. In this case, if you're looking at it, it is an SSNRI. It is used for depression. It is used for anxiety. It can be used for peripheral neuropathy, fibromyalgia, where basically patients have chronic, musculoskeletal pain. And the dosing available is 20 mg, 30, 40, and 60. So here, when you say proper drug selection, then we need to look at who the patient is, what is the age. If it's for anxiety, it is only for 7 years and older. So we have to look at the age group, we have to look at the indication, and then we look at the dose. Do we give 20 mg twice a day? Or does the indication say dosing recommendation 60 milligram once a day? So when you say proper dose selection, you have to go back to what is the problem, who is the patient, and then look at the dosing recommendations. It can vary. Next slide. And continuing on the dosing questions that they had, as I told you, for enoxaparin, it varies. Can anyone tell me the dose of enoxaparin for prophylaxis as well as treatment? What do you know? Write in your charts. What's the dosage for enoxaparin that you normally come across?
0.2, 0.3, 0.4, and 0.6. That is the 20 mg, 30 mg, 40, and 60 mg.
Okay.
Enoxaparin in the form of brand name Clexane is available in India.
In the form of?
In India, those are in the brand name called Clexane.
Okay, yeah, that's fine, Clexane. Right. So when you're looking at how much do you give for prophylaxis and how much for treatment? What's the dose recommendation?
So usually for prophylaxis, in case of stroke patients, usually given for 3 days at 40 mg. In case of DVT, they will start with 0.2 or 0.3, that means 20 or 30 mg. So depending on the severity type in the DVT.
Is this faculty talking or a student talking?
A faculty.
Yeah, see, I want students to talk.
0.8 ml.
0.8
ml, ma'am. 80 mg.
80 mg for what? Can I have interns speaking? 5th years or interns? Okay. I won't give you many answers. I want you to go back and look at the package insert. One clue. Prophylaxis is normally like a standard dose. It can be 30 milligram twice a day, or it can be 40 milligram once a day. But for treatment, it is weight-based. 1 milligram per kilogram every 12 hours. And you have a maximum dose, of how much to give. All right. So this is how you look at, when you say enoxaparin or Lovenox, you just don't say 80 mg, 60 mg. No, that's not the right answer. You have a specific dose recommendation for prophylaxis and for treatment. For prophylaxis, it's generally a fixed dose, and for treatment of DVT, it will be based on the weight. So this is one example where the dosing can change. So if you don't know the indication, then you're not going to assess the treatment correctly. And second example is the weight-based. So as you know, for pediatrics, we, dose based on the weight. Insulin, we do that. And whenever we are fixing the doses for, the basal insulins, enoxaparin I mentioned, vancomycin. So what is the standard starting dose for vancomycin? Anybody? What strengths are they available in? Can you tell me? Any student? Okay. So weight-based, many drugs, but, vancomycin, heparin, epinephrine, all these are depending on the weight. And special populations, we have to take care of the dosing. We look at the renal function and then dose accordingly. Patients who are on hemodialysis, who are on CRRT, how much to give, when to give, do we give it before hemodialysis, do we give after hemodialysis, do we need to change the dose? All these have to be taken care. And then oncology, that's a special, a department where you have to dose based on the body surface area, and then some drugs based upon the body weight. So here, as I mentioned below, there is no shortcut. Every time you see a drug, you have to go back and you have to read what is the indication, what is the dosing recommendation, what are the contraindications. So as I mentioned, for every drug, if you don't have 5 to 10 points at least in your mind, and then frequent referrals to the package inserts, you will not be able to assess properly. So there's basically no shortcut. Read, understand, and apply in your everyday case. Next slide. So here, when we're talking about the dosing, how do we dose? I mentioned for oncology, you base it on body surface area, or it can be on the weight. But nowadays, the tendency or the strategies are also changing. The scientists are also focusing on the researchers. Why based upon the weight? Why don't we have a fixed dose? So one example is Keytruda. It's used for melanoma and non-small cell lung cancer. So they have 50 milligram vials, they have 100 milligram vials. So one issue with oncology is the cost. So we don't want to have a 200 mg vial where the dose is only 50 milligram. So we want to save on the cost. We want to limit the medication errors that can happen in the dosing. All right. And we don't want to, we have to have it very simple as much as possible. So in this case, for melanoma and NSCLC, we have 200 milligram for 3 weeks or 400 milligram for 6 weeks. So the strategy here is keep the dose fixed and extend the duration. And when we're looking at oncology, it also depends upon, once we dilute it, how long it is good for, how long it is stable for. Under room temperature, this product is 6 hours. Under refrigeration, it is 96 hours. So if I don't have a fixed dose, if I don't use the entire vial, say, for example, the dose I want to give is 22 milligram, and then what do I do with the rest of the drug? Do I have another patient lined up like tomorrow where he can use the drug? If not, am I going to trash the vial? All right, so what is the cost? So here, it's not only limiting the medication errors, limiting administration errors, mixing errors, the cost, all these have to be considered before we administer certain drugs. So these have to be taken into consideration. As I told you earlier, oncology is a separate topic by itself. Next slide. Another question was what to treat first based on clinical, or what to treat first. So here, this is based upon what is the urgency, what is happening with the patient, what is the type of setting. Is the patient in an emergency room, in an IP, in an OP? So based upon the setting, based upon the stability of the patient, most important, is the patient stable? Are the vital signs stable? Look at the hemodynamic parameters, and then we go from there. So as you all know, first we take care of critical care patients, and then infections, and later we go to chronic disease. Say you have two problems here. One thing is high cholesterol levels, or the second problem is asthma exacerbation. What do you treat first? Our focus will be asthma exacerbation, and then take care of the lipid levels in the primary care setting. So this is simple to say, but when there are like 10 different problems in a critical care setting, the first focus will be to stabilize the patient, bring all the parameters under control, and then take care of the other situations. So for students, it is easy to start with very simple OP cases, and then IP, and later go to critical care. Because I have seen students who just go into ICU one day and they write 10 pages, and you have too much data. You don't know what to do with them, how to assess the case and present it. So take simple cases, spend a lot of time with them, understand them, resolve the problems, and then go to the more complicated cases. Next slide, please. There was a question on the diagnosis. So remember, diagnosis is not our job. We are not here to verify whether the doctor has done their job, whether they have diagnosed it properly or not. All right. So that students have to be very clear. Having said that, it is important that we understand the diagnosis. Why do we need to understand the diagnosis? We look at a subjective, we look at objective. Based on all these, the doctor has come to a diagnosis. Then where do we go from here? All right. So, and while you're assessing a patient, I mentioned there, with the diabetes, right? When we are writing our assessments and we say the patient is diabetic or the patient has heart failure or the patient has pneumonia, we write, if we know the scoring, if we know the scaling, it's very important that we include that in the assessment part. So we know, on what basis has the diagnosis been made, or what is the classification when it comes to the risk in this patient. And unfortunately, our curriculum does not have a focus on the physical assessment, even though clinical pharmacy topics do have some. I am not sure how many hospitals or your particular hospital has MDs give you a session. Maybe you can request for a classroom. Do you have such sessions by the doctors, Sandeep?
We have the sessions, ma'am.
Okay, on
In
based
the hospital, we have the session. Ma'am?
Based on physical assessment?
Yes, ma'am. Sometimes we'll have, ma'am. Maybe 2 months. For 2 months, we'll have one seminar, ma'am, regarding that.
Okay, that's fine. Yeah. Yeah. Next slide. Okay. Another question was assessing patient's disease based on the symptoms. All right. So, as I told you, based upon the symptoms and the signs. Do we just base it on the symptoms? I say I have abdominal pain and I don't go to school, right? That is not how you assess. You have to go back to say, what is the basis for our assessment or for our diagnosis. So you have to go back to your textbooks. You have to observe during rotations. A couple of examples I've given here. When a person is having anxiety, right? Anxiety can present in many, many ways. A person's heart rate can increase, blood pressure can increase, they may complain of chest pain, they may not be able to speak, they may cry, or they may have, they shut themselves down. They are in the room, they're not talking to anybody. They might be depressed also. So we have to look at what are the common presentation manners and then see in this particular patient, how are they presenting? How is it manifesting as? Same thing with UTI. All right. A person might have a fever, or they may complain that they're having a burning pain, or it can be the abdominal pain, So you just cannot say based upon the symptoms. You have to understand, link it to the signs, what exams are being done based on the physical examination, based upon the laboratory examination, based upon the imaging, and then assess it. So it's not easy. I'm not sure what the question was very clearly, but if I have understood it properly, everybody presents in a different manner. Next slide. There was a question on differential diagnosis. As I told you again, we are not doing the diagnosis here. So if a patient complains of chest pain, I have listed out all the reasons for the chest pain, right? It can be cardiovascular in nature, it can be infectious, it can be, pulmonary, psychiatric, atypical chest pain in a patient with, GERD, or it can be malignancy. So you have to basically, the clinician has to rule out all these and then focus on what is the reason the patient is having the chest pain. So most important is listening to the patient and observing the patient. So what I have noticed even here is sometimes there's a lot of emphasis and the focus for the doctors to do everything electronically. They are, earlier they used to sit with the patient, look at their face, observe them, listen to all their problems, make a note of it, organize the thoughts, and then use the clinical reasoning to come to a conclusion, but the days are gone. You have very little time, too many patients. Doctor has like 2 or 5 minutes with each patient, and they are supposed to do it everything electronically. So they're sitting in front of the screens. I have seen it myself here that they're not looking at the patient. They're just focusing on typing. They're making notes of whatever is the patient telling, but are they seeing the patient? Are they seeing, how the patient is sitting? What does their face say? Facial expression. What does their body say? Have they lost weight? Are they looking good? So these are the things that the doctors, apart from what the lab records say, they have to listen to the patient and observe the patient, which will sometimes give us more information. So next question, treat the comorbidities, how to identify them. So if you're looking at, there are many documents in the web where you can look a patient with diabetes, what are the comorbid conditions and to what percentage? And one example is obesity here. So I was just reading on that. Around 236 medical problems, including 13 types of cancer, is linked to obesity. So that can lead to so many other issues like insulin resistance, hypertension, lipid levels can go haywire, sleep apnea, depression, CVD. So if you're looking at comorbid conditions and you identify one condition, that may be causing quite a few problems. It's causing a ripple effect. So you need to treat that first. And even during the pandemic times, we have seen that people who are obese, people who are diabetic, the mortality and, the issues are increased in those patients. Next slide. There was a question on route of administration. I have a lot of information here. You can just go through that. So when do you choose what route? All right, if the patient is awake, alert, able to swallow, able to absorb it well, then, the oral will be the way to go. But in certain conditions like C. difficile, we give oral vancomycin. So if the patient is having a fever, we wait until 24 hours, the fever is reduced, and then we convert to oral agents. And also in the patients who are having seizures, it's important that, we do not give oral because they can aspirate. Next slide, please. So there's a similar information here. One is oral not preferred. I've already mentioned that. Next slide. Next slide, please. Okay. So these are this is a list of drugs which are generally preferred for IV to oral change because we save a lot of money, and the complications are also reduced when we do oral antibiotics. But one thing we need to keep in mind that there are mostly two drugs where we don't do one-to-one. Usually if a patient is on 500 milligram levofloxacin, we can give 500 milligram oral levofloxacin. But in the case of ciprofloxacin, it is 1:1.25, right? We give 200 milligram IV, we give 250 milligram of the oral drug. And levothyroxine, we give 50 mcg IV, we do 100 mcg orally. So these are common two drugs where the change from IV to oral is not 1:1, but it is varied. And also commonly what we see, pantoprazole, acetaminophen are drugs which are known for the misuse in the IV form in the hospital setting. So that is very expensive. So wherever possible, we need to, the patient is able to swallow, no absorption issues, then always better to give oral than IV. I think we're almost at the end. Next slide, please. Yeah, same thing. What are the advantages of changing from IV to oral? Next slide. Yep, I think we have come to the end of the session. So everything it takes, read and practice. So the more you read, the more you practice, the more you present, the better you will improve your skills. Yeah, thank you. If you have any quick questions, please free to ask me.
Thank you, ma'am. The session is really
Ma'am,
informative.
good evening, ma'am.
Ma'am, can you hear me?
Yes, I can.
Ma'am, is it possible to rule out hepatic encephalopathy by physical examination?
No.
Okay, ma'am. Thank you.
Yeah, thank you for all the time given. I'm sorry for the glitch in the beginning. We wasted like 10-15 minutes.
No.
As I told you, this was like an informal session, and with my hectic work schedule, I'm not sure how much of justice I could do within a short period of time. I had to prepare some slides, in a hurried manner. So I hope I've answered some of your questions at least.
Ma'am, for the lab value difference, you have told a textbook or something. Can you say that again, ma'am?
See, Koda Kimball has a chapter on the lab values.
Okay, ma'am. Thank you, ma'am.
And you have many lab interpretation textbooks. You have many books available.
Thank you, ma'am.
Yeah. Thank you then. Can we leave the session?
Still we have any questions? Students? Okay. Thank you, ma'am. On behalf of Chalapati Institute of Commerce Science, I thank you for presenting a good lecture for all our students. And I hope most of them have been benefited by this session, I guess. Thank you, ma'am.
I hope so. Thank you. Thank you. Bye.
Thank you, ma'am.